So the slides are visible now, sir.
Slides are visible. They're not. Kalpesh.
Good evening, ladies and gentlemen. Welcome to another exciting academic web series under the aegis of Mumbai Hematology Group, a group which stands for academic excellence and nurturing so many young talents in the field of hematology. And today's topic is one such effort in that direction. T cell lymphoma, CAR T, cytokine storm, and lymphoma associated HLH. The discussion today is going to be so exciting that all of us are going to be hooked today. All this has been possible with the tireless effort of our program director, Professor and Dr. M.B. Agarwal, sir. Sir needs no introduction, a consultant to Bombay Hospital, Leelavati Bridge Candy Hospital, an inspiration, teacher of teachers. No wonder, sir, you have been awarded with Most Inspiring Hematologist of India award by Economics Times and also Guru Dronacharya Award. All your academics, all your conferences has been a lessons in excellence, and we are extremely proud to be a part of this endeavor at INTAS. Thank you for letting us in. We really appreciate. May I request you, sir, to take it forward from here.
Thank you, Dr. Manoj, for those kind words. Today, our guest speaker is none other than Swaminathan Iyer. I'm going to formally introduce him a little later, but he's just one of us, and he's been with us all the time for our academic activities in person or through the web lectures. As was mentioned by Dr. Manoj, today he will be telling us about T-cell lymphoma, CAR T, cytokine storm, and lymphoma-associated HLH. These webinars are brought to you by Mumbai Hematology Group. INTAS has been a backbone of a large number of these webinars. Perfect Square manages all of them. And we thank the team from INTAS, headed by Dr. Manoj Kumar, Mr. Arun Hegde, and others. The team from Perfect Square, again headed by Yash, Kalpesh, and others. Executive Committee of Mumbai Hematology Group, and our guest speaker, Dr. Swaminathan Iyer. You all discussants who are eminent hematologists, medical oncologists from India and around, and the participants who log in every Saturday evening in large number to listen to our worthy speakers. Tomorrow morning, 11:30 a.m. IST, Spanish time, 8 a.m., we have Dr. Josep Maria Ribeiro from Barcelona, Spain, telling us about what they do and how they treat adult acute lymphoblastic leukemia in Spain. Discussants, we have some excellent galaxy of these discussants with us from India and around. They're alphabetically put up over here. In addition, there are many more who have joined us as faculty, as discussants, and they all are going to interact with Dr. Swaminathan Iyer, give their experience and ask questions. Formal introduction of our speaker today, MD, Professor of Medicine at University of Texas, MD Anderson, internationally recognized expert in clinical trials for cancer, with 2 FDA approvals in lymphoma and leukemia. As I said, he's one of us as he graduated from Bangalore Medical College, Rajiv Gandhi University of Health Sciences, as a gold medalist in pathology in 1994. His postgraduate training was from AIMS and then Wayne State University and the University of Miami, the American Board of Internal Medicine, diplomat in internal medicine and hematology. In addition, he has a lab interest in aptamers, CAR-Ts, machine learning. At the University of MD Anderson, Texas, he leads the T-cell lymphoma program. This involves collaboration with a multidisciplinary team in several research areas, including clinical trials with novel agents and cellular therapies, epidemiology, risk factors, and new risk predictive models. The rarity of the disease requires collaborative efforts to translate treatment advances. As the largest consortium of its kind, it could remove preventable roadblocks to collect and evaluate each TCL subtype, improve the sample collection for genomic testing, and enroll more patients in the clinical trials. Furthermore, it will accelerate the enrollment of new therapies, including histone deacetylase inhibitors, EZH1/2 inhibitors, PI3K inhibitors, SYK inhibitors, immune checkpoint inhibitors, CD47 blockers, and cellular therapies for the T-cell lymphomas. He serves as the president of the Indo-American Cancer Association with the goal of giving back service and care for patients in India. He's a recipient of several awards, including American Society of Clinical Oncology Young Investigator Award, Outstanding Physician Volunteer for the Leukemia Lymphoma Society, Virginia, Cochrane Presidential Scholar at the Houston Methodist, Who is Who in Healthcare, America's Top Physicians, 2007 till today, Healthcare Network Excellence Award 2017 and 2022. His work has been supported by grants from American Cancer Society, Leukemia Lymphoma Society, NIH, and several industry partners. He enjoys mentoring high school and college students to gear them towards the next generation of physician scientists. His Twitter handle is put up here. Today, he will lecture us on T-cell lymphoma, CAR-T, cytokine storm, and lymphoma-associated HLH. With this, I stop and hand over the platform to him.
Thank you, Dr. Agarwal, for the kind introduction. I feel privileged and also humbled by you, sir, for this invitation. And as always, happy to talk to you in what the areas that we're working on. Today is one such area, and you mentioned the rarity of the disease that we work on. And HLH is the topic today. Again, a very rare presentation, but disproportionately it takes a lot of time in our practice, in our thought process, in identification, and also the burden of patient hospitalization and family members. So we'll try to show some insights in what we have learned over the last few years. And this is the topic mainly focusing on the lymphoma-associated hemophagocytic lymphohistiocytosis. In some ways, it is akin to the topic that was stated, T-cell lymphomas, CAR-Ts, related HLH, and also the HLH that is seen from other conditions that need to be distinguished. I want to start with this clinical vignette. And this clinical vignette is of a patient that we saw many years ago. It's 7 years, and it's 7 years in July.
Swaminathan, little problem with your slides. They're not getting into the slideshow mode.
Okay. Let me.
Yeah, now it looks perfect.
Okay, excellent. Thank you. Sorry about that.
No.
So the clinical vignette, this is a typical presentation of a patient with a T-cell lymphoma who comes to the hospital because of fever, weight loss, and you do some labs and you do a PET scan. And while the patient is getting evaluated, this is the picture of the PET scan that you see. You see the bone marrow is extremely black on the PET scan. The spleen is very large and also very PET avid. And you see a lot of lymph nodes in the axilla and the neck. Invariably, this is a sign. And about 50 to 60% of these patients present with this And I'll get to this point because a lot of the criteria for HLH, secondary HLH, and the lymphoma-associated HLH is derived from primary HLH. So we'll talk about the distinctions. And there is nowhere there's a mention of the use of PET scan in determining the diagnosis. And this, I want to start off with this typical picture of how patients present with a large spleen, bone marrow completely busy, and some lymph node involvement. And then you see the patient starts to get blood work. And it's important also as a learning point that you do multiple labs. And these labs, as you can see, suggest some slightly abnormal ferritin over a period of time, but suddenly it jumps. When you have a suspicion, when the patient's present with pancytopenia,
Dr. Swaminathan, slides are not moving.
Oh, I'm not moved yet.
Okay, sorry.
I'm not moved yet. So let me see if I can use the laser pointer. So that way, can you see my laser pointer?
Yes.
Okay, good. So you can see the movement of the ferritin is very slow. It's taken many months sometimes from the time of diagnosis to the point this PET scan was done, and suddenly you see a jump in the ferritin. Along with that, you see a jump in the C-reactive protein. So all these are herald an inflammatory process, an acute inflammatory process. And I'll show you later that most patients with T-cell lymphoma have some kind of inflammation, but when they go down the slippery slope, and when the ferritin suddenly increases, the C-active protein increases, you almost always have to suspect an HLH in the setting of pancytopenia. So on the interleukin-2 receptor, the soluble receptor CD25 was done, and it is very high, 15,380 picograms per ml. I mentioned the unit because there's a lot of confusion between the picogram per ml and the units per milliliter. So that's sort of the background. With that background, hemophagocytosis was described many years ago in 1939, which is called as an atypical Hodgkin's disease because of the histiocytes eating up the other cells. And Fourcroy and Claroux described this as a familial syndrome. And then the hallmark features included the fever, the splenomegaly, which we showed, the cytopenias, and they call it hepatitis, but essentially liver enzyme elevation. You can also have altered mental status, a neurological involvement as well. And this is called as hemophagocytic lymphohistiocytosis based on this quote-unquote atypical Hodgkin's-like disease, which is essentially histiocytes and not the Reed-Sternberg cell eating up the red cells. It is not very common, but the incidence, at least in the US and Europe, is 1.2 cases per 1 million individuals per year. There are many causes for HLH. The primary causes are on the left-hand side, as you can see, and the secondary causes are on the right-hand side, at least to my right-hand side. We'll talk a little bit about the primary HLH. These are all because of genetic deficiency, typically seen in kids and young adults. It doesn't mean it cannot be seen in older adults, and you have to have a word of suspicion, a caution in this as well, and it's important to do next-gen sequencing. The perforin, I'll show you cartoons of the perforin, the monk, and the syntaxin all involved in this process. And then the secondary events, including parasitic infections, viral infections, including COVID, medications. One of the medications that I'll talk about in a way is CAR T therapy, autoimmune diseases, including rheumatoid arthritis and malignancy, which is T-cell lymphomas, right? So, and these are some of the reasons. And if you look at the geographical incidence, this is an old paper in Lancet in 2014. The most common reason, at least across the world, was this infection with Epstein-Barr virus. If you look in the USA, the map of USA, if you look at the map of China, and even in India, you can see that EBV is one of the most common causes. HIV is the second common reason. And then you have this a big bulk of this neoplasms, which is different in different settings, at least in Italy, China, South Korea, Japan, Taiwan. They're all manifestations of Epstein-Barr virus causing this T-cell lymphomas. Potentially a T-cell lymphoma, NK T-cell lymphoma, where the Epstein-Barr virus infects the T cells, or an angioimmunoblastic T-cell lymphoma, where the Epstein-Barr virus infects the B cells. So two different neoplasms, though they're all called T-cell neoplasms, the pathophysiology is different, but they're all related to the Epstein-Barr virus phenomenology. And the secondary HLH is less age restricted, unlike the primary, can be seen across the board, even in younger children and also older adults. Younger children, invariably, you have to suspect a primary process. It's very heterogeneous, as I mentioned. Infections like Epstein-Barr virus, even CMV can cause HLH, and rheumatological conditions, which you as hematologists might get to see. and also the malignancies, which we talked about, the NKT cell leukemia or the lymphoma, and the peripheral T cell lymphoma, the Epstein-Barr virus related PTCL, which is due to immunodeficiency. Now there's a new category of that. Invariably, these patients present with HLH, and then of course angioimmunoblastic T cell lymphoma, in which case you also have this B cell proliferation, which can sometimes look like a B cell lymphoma and concomitant AITL and diffuse large B cell lymphoma and cause HLH at the same time. Acute immune deficiency states, especially after a transplant, including the setting of haplotransplants, it's not uncommon, and drugs. Pathophysiology, it's very unclear, but it's some kind of trigger wherein you have this dysfunction of the cytotoxic proteins. So I call this effector dysfunction. So these cytotoxic T cells are effector cells because they are supposed to go and attack virally infected cells or cancer cells. So they are effector cells, immune effector cells, and so there is a dysfunction. They have all the components of the proteins, but somehow they don't function. So it's sort of like the counterpart of it of ED. So this is another form of ED, effector dysfunction. So it's easy for us to remember what the underlying pathophysiology is. No matter what happens, and I'll show you in the cartoon, there is this hypercytokinemia which causes the cytokine storm. It's like pouring fuel on fire. And then it also recruits macrophages, and the macrophages is part of this whole process of the problem that happens. And this trifecta creates this perfect storm, if you will. And the diagnosis of HLH was proposed by the Histocytic Society in 1991. We have an upcoming Histocytic Society meeting in Seattle in September. So we are always trying to refine the diagnostic criteria. But for the original criteria was for primary HLH. 5 out of this following 8 criteria has to be met. We talked about fever, cytopenia, splenomegaly, hemophagocytosis, which was seen and not always seen. You don't have to have hemophagocytosis. And lower absent NK cell activity, which may or may not be important because it's not an easy test to do. But what are the important ones are fever, cytopenia, splenomegaly, hyperferritinemia, so that's 4, and then CD25, soluble CD25. It has to be greater than 2400 units per ml. We saw the previous value of picograms, so there is this unclear conversion factor. It's anywhere between 5 to 6 times picograms to the units conversion. And this is one of the things we want to harmonize. But just to let you know, when you look at the values, you have to know whether you're looking at units per ml or picograms per ml. And then the other things, which are soft criteria, hypertriglyceridemia and also hypofibrinogenemia. So all you need is 5 out of 8. Invariably, we have 4 for most of these patients. And while the CD25 sometimes takes a few days to come back, so 4 plus 1, that makes it 5 to make this diagnosis. Or you can have a genetic condition, especially in children. And one of the most important factor, and that's also accessible to us, let's say you have patients with cytopenia, fever, you cannot distinguish this from underlying lymphoma, right? So because a lot of the B symptoms the patients have are present with this. But ferritin, if you just do a simple ferritin, which is available across the board, is a very sensitive test. You have the ferritin values of greater than 10,000 in children, and 50,000 in adults is very sensitive in making this diagnosis. The second thing is what we are proposing in this upcoming Histocytic Society meeting is the ferritin velocity. Let's say it was 400 to begin with. Then you have to keep repeating this ferritin, as I mentioned. It goes from 400 to 1,000 to 5,000 within a span of 5 days. So you don't meet this 10,000 criteria, 10,000 cutoff criteria, then I think that's good enough to even suspect this diagnosis of HLH. And there's lots of data to support that, including in the setting of CAR-T. So coming back to this underlying pathophysiology, perforin, as you know, is the molecule that is the lytic molecule, which is present in NK cells and cytotoxic T lymphocytes. So happens, I think I've shared the story of brentuximab as part of the work that done by my mentor, Dr. Eckhard Podak. He also discovered in 1983 perforin molecules in NK cells and T cell lymphomas, and it's a 1983 Nature paper. And interestingly, it has multiple components. It contains the MACPF domain, and it is very similar to the complement protein. Complement proteins makes holes and also helps kills the cells, right? Just as you have the membrane attack complex. And it oligomerizes with the target cell once it is released from the cytotoxic T cells, and then it forms a channel in the membrane. And the perforin alone is sufficient to lyse the target cells. And this, along with when it creates this channel or the connectivity between the two cells, between the effector cells and also the virally infected cells, granzymes are enzymes that are as a very cytolytic, then go through this immunological synapse and then they target the cytoplasm and kill the cell. The way they kill the cell is through various means, and it's independent of p53. So this is the MACPF structure and function. We won't spend much time on it, but if you look at the cartoon, so this is the vesicle of the perforin, and on the top you see those triangles and those squares. This is the vesicle maturation protein called LYST. And what happens is that there is this movement of this LYST that docks to the surface. That's a docking protein called RAB27. And this vesicle priming happens with this monk protein called 13-4. And once that happens, this vesicle fusion happens with an additional protein called syntaxin. The reason I mention all these names is that any problems with these genes that encode for these proteins can give rise to this effector dysfunction. And then eventually you have this effector function, the perforin that lines up on the surface and lyses the cell. So if you look at the model of pathogenesis, a normal process, you have a virally infected cell. And what happens when you have a virally infected cell? The dendritic cells, which are the sentinel cells, go and sense that, and then it takes in the viruses. And when it takes in the viruses, it gets mature and it becomes what's called as an antigen-presenting cell, or the APC. Once it goes to an antigen-presenting cell, it then informs the cytotoxic T cell, and the cytotoxic T cell actually matures to form those granules and the maturation process that I just showed. And when that maturation process happens, it also secretes interferon gamma, and then it kills the virally infected cell through that process of immunological synapse I just showed you. And that's the normal process. And then it can prolong, and it's a very controlled phenomenon. There is an immediate rush of these cells, and you get some fever. This is not uncommon in situations like COVID, in influenza, in various viral infections, but it's a controlled process. And sometimes when it's too much, you even use medications like Tylenol or antiviral therapies to control this process. But in the situation with effector dysfunction, what happens is that you have the same dendritic cell that takes in and presents to the cytotoxic T cell. There's a problem with those proteins. The proteins don't function well, the perforin proteins, but it is able to secrete interferon gamma. And when it secretes interferon gamma, then this gets this feedback to this dendritic cell saying, I don't know, I need more help. So the dendritic cell in turn produces more dendritic cells. It recruits more T cells. And what happens in the process is that you have increased secretion of interferon gamma and increased proliferation of T cells and macrophages. It's sort of chaos because you don't know what to do. And the end result is that a virally infected cell is untouched. Instead, you have this process where the cells are proliferating. It's almost like you're driving a race car, but you're not moving. You're sitting in one place and pressing on the gas pedal and creating a lot of smoke and noise. So it's sort of the same analogy here. And this diagnosis of HLH, from a primary HLH perspective, is all these proteins that I just talked about, the perforin 1 protein, the MUNC 13.4, the STX11, etc. All these are proteins that have been described. You probably have read this in your boards, the Cheriak-Higashi syndrome and the Hermansky-Pudlak syndrome, which have to do with vesicle trafficking. They're rare, but there are populations of these patients present in southern United States and Puerto Rico, etc. But it's important to know these mutations. In addition, you have certain mutations that can predispose to Epstein-Barr virus, such as the CD27 and the CD70 and various other proteins that can also cause this. So this trifecta of the storm causes proliferation of T cells, macrophages, a lot of cytokines, and causes tissue destruction. And I'll show how this pathophysiology is important because we can potentially affect these pathways one way or the other, either at interferon gamma pathway or the secretion of the cytokines, or even by using medications such as ruxolitinib. So I take this license from the CAR-T picture where you see the cytokine pattern of axis-cell. And we actually did a study comparing all the different cytokine storms, and I'll come to that in a second. If you take CAR-T, because we understand this model very well, it's iatrogenic, if you will, of creating a cytokine storm, though not an HLH always. It's very rare in that setting. You give conditioning regimen, the IL-15 goes up, and then you have the CAR T cell infusion. There is expansion of CAR T cells, and then you have this cytokines, which comes in waves. The initial cytokine is an immune homeostatic cytokine, and then you have the inflammatory cytokines, which is marked by this IL-6, and the patients typically have fevers, and this is the middle phase. And then you have this immune effector molecules, which is the granzymes and the perforins, the same thing that works by going and killing those the CD19 directed B cells in there. That's a perfect model. But what happens in this situation of a lymphoma, for example, think of the same set of cytokines. You have this homeostatic cytokines that this cells are trying to produce in this dysfunctional status. There's a disproportionate secretion of interferon gamma and some IL-6, some IL-1 beta. And then you have this immune effector molecules, which does not function. So this effector dysfunction gives rise to this process of cyclical nature, and it's a vicious cycle that leads to this storm. And the role of macrophages is also important. It was identified very early on in 2006. And if you look at the macrophages in this immunofluorescence, you see large macrophages which are eating the other cells, because macrophages, as you know, are also helpful in sequestering ferritin. These are C163 marked cells, and they also end up eating the other red cells because of this wrong signal that they get, because they don't know what to do. They're sitting right there. And what is important is that if you use interferon gamma antagonist, you're able to shut down the activity of the macrophages. And I'll show you how this is useful in therapy. And we also will show you a clinical trial that is a late breaking abstract last year of depleting the macrophages that can also give rise to the same relief in this HLH-like process. So the cytokine storm is, as I mentioned, is a spectrum, all these different causes. And genomic studies, are they required for all the patients? I think if it's definitely a child or adult, young adult, I think it's very important to do that. And there are several studies which actually point out that there's a familial HLH and the secondary HLH overlap. So whenever possible, I think trying to send us NGS panel is important. There are specific panels that are done by Mayo Clinic and by Cincinnati. So we normally send to them, and it's helpful for us to get that list of proteins that I just showed you earlier. And the etiology and features, we won't get into much of this, just showed you this Ramos paper from Lancet 2014 with all these different possibilities. But most importantly, if you look at the quality improvement initiative for us hematologists who look at causes, malignancy seems to be the disproportionately higher number. This is data from Johns Hopkins. You can see some Epstein-Barr virus, but 38% of malignancies, and a majority of them are T and NK cell lymphomas. Why is it important? If you look at the outcomes, it's probably the poorest of the lot. If you have infections and even Epstein-Barr virus to some extent, you have idiopathic causes, you can treat them, rheumatological conditions, you can treat them. But if it's malignancy, it's really difficult, especially if it's a T-cell malignancy. And I'll show you the data for that. So a word about MAS and autoimmunity. Macrophage activation syndrome is the other term, because macrophages get activated. It's generally used in the context of autoimmunity in the setting of idiopathic arthritis. There is some subclinical bone marrow evidence in about 50% of patients with juvenile rheumatoid arthritis. You do get fevers, anemia. Sometimes you get hepatosplenomegaly, definitely elevated serum protein. These are all the conditions that are associated with it. But the most important thing is that they have a different criteria. The lab criteria is you have thrombocytopenia. You don't need the bicytopenia, elevation of AST, leukocytosis, and hyperfibrinogenemia. And you have some other things in severe conditions such as the CNS dysfunction. And you need 2 lab criteria and 2 lab plus clinical criteria. And your ferritin levels just have to be 500 nanograms per ml or more. Why? Because today you have 2 drugs approved for this condition. One is tocilizumab and the other one is anakinra. And it's very effective in this situation. It's a different situation in T-cell lymphomas and perhaps even in CAR-T, but clearly in the setting of MAS, it's very important. Infections, we talked about infections, which is described many years ago. You have a whole list of infections, but the EBV is probably one of the most challenging. If you have EBV that is seen in the setting of B-cell lymphomas, or even in AITL, where 99.9% of the time it's the B cell that's infected, you can use rituximab and various approaches to treat this. But in the T-cell lymphomas, we struggle because you treat the malignancy, the immunosuppression gets worse, the Epstein-Barr virus thrives on this, they are already in a lytic cycle, and they make things worse. So one of the things that we have been doing is to improve the immune situation, and we have what's called as a cytotoxic T-cells directed to EBV that has been approved in Europe. Atara Biotherapeutics has a cytotoxic T-cell that is approved for PTLD. The same CTLs can also help treat the situation once the cytokine storm is under control. So that's EBV. Just to show you this 8 criteria. If you look at all the criteria, right, the sensitivity of these criteria this is a prospective study from China looking at all these various conditions. Ferritin and fever are really important, and maybe to some extent soluble CD25. If you can do NK cell activity, it is. But hemophagocytosis may not always be the case. Splenomegaly, bicytopenia, they're all important. But if you look at that, if you draw a line there, you can miss a lot of these patients because they don't have hemophagocytosis or bicytopenia. When you have a clinical suspicion, it's important to start therapy for the HLH. A word about ferritin. Ferritin is an iron store. We all know as hematologists, but it actually has 2 isoforms. It has the H isoform and the L isoform. The L isoform is the one that increases dramatically in hyperferritinemia, and macrophages can sequester those anyway. And ferritin values are, as I mentioned earlier, is anything more than 10,000 is important, or anything that has a velocity that's increasing in time. We've not determined what the speed has to be, but even in the setting of CAR-T, in the setting of HLH, you need to, there's a ferritin velocity is probably going to be more important than the actual absolute values. Soluble IL-2 receptors, also there's a threshold. There is this threshold that is different for secondary HLH due to autoimmune conditions and due to other diseases. And it appears that the lymphoma HLH have inherently very high soluble IL-2 receptors, because if you look at the first biomarker for hairy cell leukemia and several other B cell malignancies, the Japanese have been at the forefront of using this particular biomarker for monitoring the disease and also the bulk of the disease, just like beta microglobulin. So inherently, there is a high soluble IL-2 receptor. On top of that, if you have HLH, you have a very high skewing of this biomarker. And so there have been very different approaches. As I mentioned, 2400 is the cutoff for the HLH, primary HLH criteria. And if it's less than 2400, you probably could exclude HLH because the sensitivity is 100%, but you have to do multiple values. The problem is, just because you have one value that is 1500, it doesn't mean anything. Usually the upper limit is 800. You need to do at least 0 values. And if it's greater than 10,000, invariably units per ml, it is HLH unless otherwise specified. The French came along with this H score, which is actually useful. It doesn't have the soluble IL-2 receptors. It has conditions associated with immunosuppression, along with the other things that we talked about. And this score also gives you a prediction. And many of you, I mean, all of you can actually go to this website in Saint-Antoine in France. It's a pediatric hospital, and you can actually calculate the scores by putting in all your values there. Many years ago, we came up with this optimized hematological inflammatory index, or the OHI. The OHI is an international collaboration that is led by Dr. Adi Lorenz from Israel and Michael Jordan, who did the first studies with anti-interferon work. And what we showed is that if in the setting of malignancy, not other secondary HLH, and particularly lymphomas, and we are not and I'm not sure about leukemias, but if you look at secondary HLH, lymphoma-associated HLH, just getting ferritin and soluble CD25 is sufficient to make a diagnosis of HLH, and also for prognostication. Very high OHI values have poor prognosis, and very high OHI values, and the threshold is you have a ferritin beyond 1500, and the threshold for the soluble IL-2 receptor is 3900 in this original paper. But I think that can vary. I think can be settled down on 2400 as a useful value. And why is that important? Because if you look at NHL with HLH, or the B cell lymphomas like diffuse large B cell lymphomas, or T cell histiocyte rich B cell lymphomas, where you always see HLH and nodular lymphocyte predominant sometimes, the difference of PFS and OS, you can see, is actually reasonable. But if you look at T NK cells with HLH, you see the survival curve is way below here. And what's the difference? The difference here is there's no rituximab like biological activity, except maybe in the settings where CD30 is positive, and CD30 perhaps can bridge this gap. But we are struggling, and hopefully the newer therapies that we have will help with this condition. What I also wanted to show you in the T cell lymphomas, and this is data from our own center, work done by Amrit Gunagunta, presented at ASH last year, shows that patients with T cell lymphomas, if they have HLH, and the Kaplan-Meier curves, the mortality, the 60-day mortality is pretty high. It's anywhere from 30 to 50%. And it's very important for us to identify this in the setting of T-cell lymphomas particularly, and also B-cell lymphomas, whether they have underlying HLH or not. And as you all know, patients with B symptoms have some cytokine phenomenon. So it's a spectrum. It's a spectrum from a B symptomatology to the other end of the spectrum, which is the HLH-like condition. But you need to know when to intervene, because if you do find that there is the HLH-like process, you have to definitely, for B-cell lymphomas, use Rituxan, and you have to use etoposide in the setting of lymphomas. Medication-induced HLH, I won't get into the details of this, but I want to spend a few minutes on CAR T. CAR T has become the mainstay of therapy for B-cell lymphomas all over the world, including in India. Though CAR T, there are many factors that lead to this HLH, and this condition is called IECHS, which is immune effector cellular therapy associated hemophagocytic syndrome. So very different. You don't have to have the classic criteria. There's a guidelines. It's not based on any validated data set. What we do know is once they develop CRS after a few days, that cytokine storm that you see, sometimes the CAR T cells persist beyond 7 days. And by day 14, you start seeing drops in counts, which invariably can happen because of lymphodepletion. But suddenly you see increases in liver enzymes and also ferritin. That should be the alert for you to say that this is a CAR T associated HLH. And why is that important? Because you can potentially save these patients by giving them a combination of IL-1 beta or IL-6 antagonists. And the CAR T expansion is one of the reasons. But what is different about this is that there's a hyperferritinemia. The velocity here is important. 10,000 again has been the guideline from consensus, but the velocity is more important. Hepatic transaminitis, which you don't see in the primary HLH. If you use the same primary HLH criteria, you don't see this. And then you have hyperbilirubinemia and coagulopathies. In the order of things, these are some of the situations that you have to consider. Rarely, you can also have pulmonary manifestations. We had a patient post-CAR T with isolated CNS HLH. So you have to have an alert, and sometimes it's not always clear. So we did a study of about 700 patients comparing the different types of cytokine storms. Looking at CAR T-associated cytokine storm, COVID-associated cytokine storm, which we defined based on IL-6 and C-reactive protein and ferritin and HLH. What we found is that the survival is very different. And some of the insights, clearly there is a difference in terms of the hospital morbidity for HLH patients. And they also didn't respond to tocilizumab because this is a retrospective data set. So we didn't actually know what is happening. Many of these patients didn't do well. If you look at some of the labs, the lab value thresholds are much higher. The D dimer was higher in COVID, much lower in CAR T, fibrinogen lower in HLH. And also the soluble IL-2 receptor and the ferritin levels were much higher in the setting of HLH. So when we did the study, we also showed that the signaling pathway. If you look at the CAR T, which is marked by this red and by this COVID cytokine storm, they're sort of clustered together in this clustering. And this HLH is very different. So this clustering here is IL-6 mediated. So many times CAR T, you can give tocilizumab, that's why it helps, or anakinra, it helps. The same thing with COVID. But in HLH, perhaps these patients were found later on in the course, and these medications actually did not help very much, at least in our lab, in our series. And these are the differences in the lab value, heat map. And you can read this in JAMA Network Open that was published early this year. More importantly, why is it important? Again, the same outcomes for HLH, it's pretty poor. And majority of these patients were T-cell lymphoma patients. So how can we salvage these patients, right? So we have some ideas. We'll get to this. Not all cytokine storms are equal. And this is actually data from our center to show that, it's important for you to consider the type of secondary HLH. Some clinical vignettes. This is a patient with the extranodal NK T-cell lymphoma with lesions in the neck and was treated with a SMILE regimen. I think you can see that this is the value of ferritin, which increased with time. And then you can see that this is the value of IL-2 soluble receptor. The patient did receive tocilizumab and temporarily was controlled. And it's important for us to do this very early on in the process. So the treatment of HLH, essentially going back to 1991, when the proposal came about, was to come up with this HLH 94 protocol because it helped the pediatric population. Why? Because in 2002, subsequently, Henter showed that the survival rate was 80%. And the protocol was updated in 2004, including adding allogeneic transplantation. So what's the difference between 1994 and 2004? You had the steroids, etoposide, and cyclosporin, and then you had intrathecal methotrexate. And the pre-transplant mortality was 30%. And the 04 had dex, etoposide, cyclosporin only in the induction phase, and then the intrathecal methotrexate plus steroids, and the transplant, pre-transplant mortality was slightly lower. And it's important that this HLH-04 criteria is instituted right away. So this is a simple table that I made. If you have a family history positive and there are families with HLH, then clearly you need to have HLH-04 treatment protocol with transplant, or now, if it's available, emapalumab, and I'll show the data for emapalumab followed by transplant. And family history is negative. For primary immune defects, you follow the 04 protocol. For secondary immune defects like the CMV or the herpes, you treat the underlying condition. For HIV, treat the HIV or the secondary effects of HIV, such as CMV and herpes. And for cancer, you have to treat the underlying cancer, but not always the case. The aphorism that you treat the cancer, HLH gets better, is true for B-cell lymphoma. It's not true for T-cell lymphoma. And so it's important for us to distinguish this. And I won't get into the details of this. And this is the HLH-04 protocol, which is already published. And for the MAS, which I showed you earlier, you can give steroids, but more importantly, anakinra, tocilizumab, ruxolitinib. There are multiple JAK inhibitors that have been approved. All these things help in the treatment, including rituximab. I will get to this, coming back to this trifecta of storm of HLH. You saw this proliferation of T cells, macrophages, and the interferon gamma increase. So this is a mouse model showing that if you use ruxolitinib in the murine models of HLH, they actually can reverse some of the conditions associated with cytopenias and also the cytokine storm. In fact, the Chinese protocol currently is using ruxolitinib and dexamethasone. They use a DEP protocol if necessary. They use this as an induction regimen, and if their patients respond, they go on to this chemotherapy. And it's very successful. It's been very successful for EBV-associated HLH. And not so much for lymphoma-associated HLH, but ruxolitinib is a mainstay and it's available in India. Anakinra is another drug that's very important, and you have to consider this. Tocilizumab is another drug. But the story with tocilizumab and anakinra, for this matter, and you saw this phase. The IL-1 beta secretion is a little earlier than tocilizumab. You need to know when to treat, and this treatment has to happen within the time of diagnosis. We have a manuscript in preparation in leukemia particularly, which is very different from lymphomas, since this talk is on lymphomas, where we see that treating the leukemia doesn't treat the HLH, and you have to get the velocity, and sometimes there's a delay in the diagnosis, and using toci or anakinra late enough doesn't help. So the timing is very, very important in this situation. And this is a patient, again, with an NK T-cell lymphomas. The lady in 2018 who, and just to show that HLH can happen anytime, it doesn't have to be a diagnostic condition, received SMILE regimen, completed on 5/9. On 5/10, ended up having this dyspnea and pyrexia. You can see this increase in the ferritin values. It suddenly increased. And she actually did have an underlying cardiac condition, which gave rise to this cardiac dysfunction. And we recognize this based on this ferritin velocity that she was developing HLH, and she was treated with a 94 HLH protocol and tocilizumab and was controlled. And subsequently, what we found was that when you treat these NK T-cell lymphomas, you have breakdown the Epstein-Barr virus. So it's the values, we don't have the baseline, it increased suddenly to 313 copy numbers. And with time, it actually gets better. So you can think of this sort of a tumor lysis syndrome manifesting as HLH in the setting of NK T-cell lymphoma. So you have to be careful that even between treatments, interval points, you can also have HLH. You can also have HLH when somebody gets immunosuppressed, gets secondary CMV infection. So don't be fooled by the fact that it only has to be a diagnostic presentation. And so I'll get to the personalized treatment. I think it's important to keep that in mind. I'll skip to anti-interferon gamma. And I showed you earlier that Michael Jordan did some work in macrophages and showed that suppressing the interferon gamma actually helps these patients. So this drug was developed, emapalumab, anti-interferon gamma antibody, and this is presentation by Dr. Lucavati from Italy. This is a plenary session and also New England Journal paper of using this in patients who failed HLH-94 protocol, starting with 1 milligram per kilogram, and then increasing it to 3 days later, and then 6, and doubling all the way up to 10 milligrams per kilogram. And with this, you can see the complete response rates were 21%, and overall response rate of 63%. Only 27 patients were enrolled, but had a 70% proceeding to transplant, even with partial response. And one of the things that is really missing, whereas we have this primary HLH criteria, we have adopted that for secondary HLH and lymphoma-associated HLH. We might have the OHI to help us with lymphomas. We don't really have response criteria. So what they did in this publication is they modified this response criteria, and they came up with this Lokawati response criteria, which at least has CR, which is no fever, no organomegaly, normal ferritin, which is very high bar to set. And then you have partial response, at least 3 of the HLH clinical and lab findings have resolved. And you have the HLH improvement criteria. It's important, at least in the setting of IECHS, for example, to consider the right treatment for and emapalumab is perhaps one of the most important therapy. Unlike the HLH due to primary reasons, where the emapalumab was given over a period of 2 months, for CAR T related HLH, you just need to give 2 or 3 doses, and that's all you need. And we have a series of 5 or 6 patients that responded dramatically with just using this emapalumab. The problem with emapalumab is not that it works well; it's very expensive, and the cost of the drug can be anywhere from $1 million to $5 million. Most hospital systems do not want me to utter the word emapalumab. So every time we have a patient, it's a fight between the hospital systems because it doesn't get reimbursed. The indication for emapalumab is the primary HLH and not the secondary HLH, either due to lymphoma or due to CAR T. So that brings us to this very classic approach of depleting macrophages. I showed you the center of this pathophysiology is this macrophage that sort of reads the situation wrong and thinks that it needs to activate more T cells, whereas the proteins are not functioning, the effector proteins are not functioning. So ELA26 is a pan-SERP. SERP, you've all heard of SERP alpha with the CD47 protein analog, CD40 protein receptor. And you have the SERP alpha, not just alpha, but you have the beta and the gamma. So this antibody targets all these different isoforms and it induces ADCC. And it does not inhibit the SERP alpha CD49 axis. So it does not like your approach of treating B-cell lymphomas. So what it does is it depletes the monocytes, which eventually become macrophages in the tissue, and also depletes dendritic cells and cytotoxic T cells. So we did this first-in-class study. Dr. Abhishek Maiti in leukemia was the first author, and all the patients that we enrolled were T-cell lymphomas. There were 3 cohorts. The first in human was mostly dose finding, and then you can see that the responses very early on in relapsed refractory HLH in the first few patients was pretty high. You can see that many of these patients crossed the 6-week barrier. In fact, one of the thresholds for HLH response is the 6-week response, and that's accepted by the FDA. So this is going on to a pivotal study. And we saw many of these patients with Hodgkin's lymphoma performing really well, ALL patients really well. PTCL patients, not only did the HLH get controlled, but also the T-cell lymphoma also was controlled. And we had a presentation at Lugano of about 7 patients with AITL and PTCL, T-cell associated B-cell lymphoma, showing that the HLH was controlled and also the underlying lymphoma as well. And what are the side effects? Is cytopenia, because it is a non-target effect, and also infusion-related reaction. So you have to use dexamethasone in this setting. And there is this priming dose, which is IV, and then subsequently maintenance is sub-Q. I don't have this case report of this patient who came from China with cytotoxic T-cell lymphoma. Had one of the largest spleens, 27 centimeters. Couldn't get any of the treatment. So we had a compassionate use emapalumab early on in December, and completed 12 weeks of therapy and went into complete remission. The next step was to get the patient to an allogeneic transplantation. So it's important to show that this not only targets the macrophages, but also takes out the cause in this situation, which is the T-cell lymphoma. And these are some of the response rates seen based on the modified Locatelli criteria, mostly PRs and 1 modified CR. You can see drops in ferritin, C-reactive protein, soluble CD25. And this is improved survival, which I mentioned. The 6-week threshold is now moving forward as a 56-day threshold as an endpoint for patients. And as I showed you, the survival is anywhere between 30 to 40%. But with this, you see close to 100% survival by 6 weeks in these patients. So once HLH is controlled, you can send them to transplant. But invariably, many of these patients don't have a control and it can relapse pretty quickly, and there's not much we can do. You can retreat them. And this is the DEP regimen that I was talking about, using the liposomal doxorubicin, etoposide, and methylprednisolone. It works sometimes, but the response rate is much poor. And these are situations where you have to consider these patients on clinical studies if they have good performance status. And you can see that the responses are not very good in these patients. And I think these are some of the last few slides. So show that series suggests that the outcomes in secondary HLH is poor. You have to control the infection. Etoposide is crucial in Epstein-Barr virus associated processes. And O4 should be initiated as soon as you suspect this in LA, in lymphoma-associated HLH. Not only should you use HLH94, but you can consider using tocilizumab, anakinra very early on in the process, and also consider them for clinical studies and get them to a transplant as quickly as possible. So what I just showed you, and it's a whirlwind of a storm. In fact, it's a potentially fatal condition. We are trying to understand the storm. It's chaos. And it can be easily missed in patients with cancer because we think that they all have B symptoms. We think that treating the underlying lymphoma treats the cancer, when it is not the case. And the goal is to improve awareness, and have this at least ferritin and this criteria, at least 4 of those classic criteria, until we come up with new things. Or you use the OHI criteria for lymphoma. You have to have a high level of a suspicion to start treatment of these patients. Otherwise, it's a potentially fatal condition. And this is the only way we can improve this. And so we call ourselves as stormtroopers, at least in MD Anderson, because we chase these cytokine storm. And I think it takes more than a village to get this under control. And I think I'll stop here. And this is a poem that you all are familiar with, from Robert Hutchison: "From making the cure of the disease more grievous than the endurance of the same, good Lord, deliver us." Thank you.
Thank you, Dr. Samin. That was fantastic. You updated us on this subject beautifully. So we have our colleagues here who would like to interact with you. And I would like to ask you one thing about etoposide. We do face some difficulty in using this because we end up with very severe cytopenia and then secondary infection. So do you use it very liberally or very cautiously? Doses, duration?
Great question. Sometimes with lymphoma, I think one of the ways to use etoposide is to use it along with CHOP or SCHOEP or EPOC, and that's one way of doing it. The other way, of course, is to give it 1 dose a week. Though the O4 criteria says you can do up to 2 or 3 doses a week, you can give anywhere from 75 to 150 milligram per meter square. Maybe day 1 and day 3 or day 5. And yes, you're right. I mean, it does prolong the cytopenias and can worsen this. But many times what we have seen is that you will see a big drop in the counts and you'll see some recovery. That's a good sign. If it doesn't recover by week 2 or week 3, and there is this response criteria, there is this stable and unstable response criteria. So you need to have at least a stable response for 3 to 4 weeks. Let's say you get a response and some stabilization, but then HLH flares off, you have to keep giving at least a dose of etoposide every week until things are under control.
And how do you decide about whom to give TOSI?
At our place, we actually moved to anakinra because we found the TOSI dosing is once every 2 weeks for this situation. In anakinra, you can dose this from 100 to 200 Q8. So we have rapidly moved to anakinra. We don't use TOSI as much, except in the setting of outpatient, because you can't get that as an outpatient setting. When we have a suspicion and we can't go on a clinical study or have relapsed a refractory HLH, I think we use this very early on in the process. So we start steroids. So there's a steroid taper over 6 weeks. You can give etoposide. As you mentioned, etoposide worsens. So then you start adding anakinra. Anakinra stabilizes the whole process, so you don't have to use as much etoposide, and you can also taper the steroids over that 6-week period.
Any role of IV gamma globulin and cyclosporine?
Great points. I think those are easily available. If you were to use IVIG, though there's no data, but as anecdotes that it helps, I think you should use it very early on in the process. definitely the cyclosporin can be used. The problem with cyclosporin, as you know very well, Dr. Agarwal, is the therapeutic window is so narrow, and then you already have toxicities, and you're trying to control the renal side effects and hypertension and whatnot in the setting. But I think in lieu of everything else that's not available, the lactose or anakinra, I think these are good options to consider. I think ruxolitinib is perhaps another very important option in this setting.
Right. Dr. Gopinathan, your question.
Yeah. Good evening, sir. Thanks for enlightening us with the new concepts of HLH and lymphomas. So I have one practical patient where he was a 65-year-old man who had AITL. He received CHOP-based therapy. After 5 cycles, he had a short fever, loose stools, and then he presented it to us with frank HLH. So my first question is, at this point of time, like when he was almost responding to the therapy, CHOP-based therapy, the infectious markers that we did, the CMV, EB, all came negative. So should we think at this point of time the disease is still active to cause HLH, and how should we proceed in this situation?
It's a good point. Even though EBV may not be detectable in the serum, right? So you do the EBV by PCR, not serology, because if you do serology, it only gives you the past infection. You need to really do the PCR, and especially in the setting of neutropenia, that's the only sure way of knowing that it's in the lytic cycle. But if you look at the B cells in that setting, invariably they all have EBR, at least as a marker. In this setting, at least I would try and give rituximab, and I illustrated the case. So don't be surprised that this happened. I'm not surprised because at some point there is this process where this effector dysfunction happens for the cytotoxic T cells, whether it's due to EBV or by the underlying disease. The assumption here is it's probably B cell driven and probably EBV driven. So I think giving a course of rituxan after you do the PCRs and also the steroids and just the etoposide, because you've not given etoposide along with the CHOP, I think that would be a practical way of treating this patient. I think Rituxan and AITL, it's a big conundrum, right? I think there are situations where Rituxan actually really helps, and we don't have a study, and that's one of the questions we're asking. So that's how I would approach this.
Yeah. So this patient's EBV was negative, PCR was negative, CMV was negative. But he developed HLH during therapy. So my doubt is like during, if at all it is a lymphoma associated HLH on therapy, what are the possible pointers that can make a flare? And if at all they develop HLH, can we develop it's going to be a refractory course?
Great question. There is a Swedish registry. There is another, I didn't discuss this because, as such, the cytokine storm is complex. There is a chemotherapy induced HLH, and it's more common in leukemias. If you look at leukemias, and if you look at the timeline of leukemias, by about day 10, day 14, when the cytopenia is at the peak, you get HLH. And the Swedish registry actually looked at it, and they found like 6 to 10% of the leukemia patients actually develop this. We see a similar phenomenon in T cell lymphomas, and I gave you the example, at least in the case of NK T cell lymphomas, we could see the EBV. We had another patient which is due to CMV, or a couple of patients due to CMV. So the other possibility is chemotherapy associated HLH. That can be very difficult to treat. Again, it's not very common, but no matter what, I think you don't have, it's like a black box here. So you still have to throw a lot of things at this. And you have the mainstay, which is HLH 04 protocol. So if you think that you strongly are confident clinically that the EBV is not involved here, then I would use anakinra. Anakinra would be the best approach, or ruxolitinib. And ruxolitinib, I would emphasize because it also is an anti-T cell lymphoma therapy, and I think it's been combined with romidepsin, at least here. And it's a good medication that we've used with azacitidine. So if you were to treat this HLH process, I think you don't have romidepsin in India, but you do have azacitidine, and it works well in the setting of AITL. So we have combined azacitidine with ruxolitinib as a treatment, and I have a couple of patients who are on it for a long time.
Thank you, sir. Thank you so much.
The question in the chat box from our Myanmar colleague: how do you suspect HLH in bone marrow transplant patients? How do you diagnose and how do you treat?
Yeah, so that's a different scenario. We didn't talk about that, and I think the risk is high in unrelated donors, if there's a mismatch or even a haplo mismatch. I think those are the situations, or you have some kind of a change in the immunosuppression that happens and that allows viruses such as CMV and Epstein-Barr virus to cause this phenomenology. And the diagnosis is not very different. I think you have to have a suspicion because you have multiple other things that you have to consider in the differential diagnosis. But the set of criteria is very similar. You look at elevation of ferritin, which can be seen in a lot of post-transplant conditions, the cytopenias, which goes, it's a check mark for HLH and EBV-related infections, hepatitis, or the liver enzyme elevation that you see can be seen in GVHD also. So sometimes it can be misleading, but you would send an IL-2 soluble receptor, all these things. And invariably, if you have EBV, I think it's a suggestion that it's an EBV reactivation or lytic cycle in the setting of transplant, and I would treat this. Doing a bone marrow will help because even if you see the bone marrow, there's no evidence of disease. What you sometimes see is the presence of EBV, scattered EBV in the B cells. That I think is alone sufficient to make a diagnosis, and then you would treat this in the setting of the clinical criteria treated as HLH.
Thank you. Dr. Krishna Kannan.
Thank you. Hi, Dr. Swami. Nice talk. The question I had was, did you say that it can happen in B-cell lymphomas also, this HLH, and how frequently you see in B-cell lymphoma?
It is not very common in B-cell lymphomas, but there are the rare varieties of B-cell lymphomas where you see it, especially in the double hit lymphomas with stenoidal manifestations, particularly in the refractory state. T-cell history-set-rich B-cell lymphoma, it's about 30% of those patients actually present with fever and HLH-like conditions, nodular lymphocyte predominant, that progresses. And I think there's a blur between the diagnosis and T-cell history-set-rich B-cell lymphoma. And those situations, you actually see an HLH-like manifestation. Of course, when you give CAR-T, the incidence of CAR-T associated HLH is less than 1%. It's low, but you have to have a high index of suspicion. So in B-cell lymphomas, these are some of the subtypes that invariably you have this.
Okay, the other question I had was, in a T-cell lymphoma, when they present with the HLH, you ameliorate the HLH and then take them to the T-cell lymphoma protocol, and then you follow it up with a high-dose therapy and autologous transplant for a T-cell lymphoma.
So great. I mean, so the thought process is is good. So you start off with the HLH-04 criteria. So because you can, by the time you're waiting for the diagnosis, you can give them a steroids, you can give them etoposide. The other way to do it, if you're very sure of the diagnosis and the patient's liver enzymes are not elevated, is to use CHOEP, right? So because it has etoposide, 3 doses in it. The other way, if your liver enzymes are elevated, you're sure the diagnosis is what we have done, is to use hypercytoxin dexamethasone, which is the same hyper-CVAD, take out the adria, take out the vincristine, and use that. And why? Because it doesn't affect because sometimes doxorubicin and vincristine that's metabolized in the liver can worsen the hyperbilirubinemia. So you have 3 approaches for T-cell lymphoma. And if you use the 04 criteria, I think it's important that in about 30 to 40% of the time, that's sufficient. You are able to salvage these patients. But if you don't get a response within the first 2 to 3 weeks, you have to start considering adding anakinra. And if it's AITL, I would definitely add Rituxan very early on.
So ultimately, for T-cell lymphoma, is it okay to go for a autologous transplant?
So I don't know that there is a right answer, but for T-cell lymphomas, if the HLH is under control, and it's a controversial topic even in our group. We've done auto transplants, and I don't think it cures these patients in the long run. Even in the setting of T-cell lymphomas, if you're able to control the disease, it gives you a long disease-free interval. And especially when there's a trigger of HLH, I think my sense is to take them to an allo transplant for the right patient, a young patient with chemoresponsive disease or not. I think taking them to an allo transplant is probably the best approach. Can you do an auto? Yes, you can do an auto if the HLH is controlled, if the disease is in remission. right? So you can only take them to an auto transplant when the disease is in complete remission. So if it meets the criteria and you don't have other options, I think auto is reasonable.
Yeah, just one last question. Paniculitis, like T-cell lymphoma, that's very notorious to present as HLH, right? And what transplant? Again, we offer an allo transplant for them.
So it's an interesting point, and it's not very common. So SPTCL is the alpha beta type of paniculitis like T-cell lymphoma, subcutaneous, and there's a gamma delta variety too. And both of them are extremely rare. And it depends. If you have young patients with SPTCL and there is an underlying autoimmune process, you can treat them with the O4 criteria with cyclosporin, because there you have an autoimmune phenomenology that helps you control this process with cyclosporin and combination of steroids. And we have patients who have done well without anything else. But if there's a relapse and the cyclosporin doesn't help, and if the immunosuppressive process doesn't help, invariably the second line approach that you have to do includes even a O4 criteria. Then that is when I think an allo transplant is very useful. We've transplanted a few patients with SPTCL and primary cutaneous gamma delta T-cell lymphomas, but all the situations were because the disease is very aggressive or did not respond to the first line therapies. So there might be situations where you don't have to treat this. Now, there is this association with this protein called HAVCR2, also called as TIM3. TIM3 is a checkpoint inhibitor, and the mutation of that protein has been shown to be associated with HLH. So if you do find TIM3, it's a germline mutation, then you have to invariably consider an allogeneic transplantation, because you do have a germline mutation. This thing can recur again, and that's a situation where you do an allo transplant.
Okay, thank you so much.
Thank you, Dr. Kannan.
You, Dr. Roshni.
Good evening, sir. Thank you for that very informative talk. My first question is, can HLH occur in CML patients?
Yes, and myeloid malignancies are not uncommon at all. It can happen in any setting, but these are the most common varieties in myeloid leukemias, especially when there's a transformation from a chronic phase to an accelerated phase or to leukemic blast crisis. I think it can happen. I think a lot of those, at least in MD Anderson, are treated by our colleagues. Dr. Naval Davar is my HLH counterpart in the leukemia department, and he has a handful of patients, but yes, it can happen. It can happen even in myeloma. We have seen patients with lenalidomide-associated HLH because of the immune activation and the effective dysfunction that happens.
The second question is, does HLH always herald a relapse in NK T-cell lymphoma? I mean, do
Yes,
we
that's
need
a
to
great
do
question.
the Iberish always?
That's a great question. And so let's say you treat a NK T-cell lymphoma, stage 1, stage 2, chemoradiation, and then the patient presents with HLH. Invariably, that does herald one thing for sure, that is EBV. If EBV has gone into lytic cycle, you can have a small focus of the NK T-cell lymphoma. It may not be in the nasal cavity. Then you have the other type of EBV lymphomas that are not, that's not extra nasal associated EBV lymphomas, which presents mainly in the bone marrow and the spleen. And in that situation, you don't need to have a whole lot of leukemia or lymphoma, whichever one you want to call, but you do have this. So you have to treat both the HLH and also the underlying the leukemia lymphoma. You can treat the HLH, but the problem here is controlling the EBV is very hard, and you have to treat them quickly and try to get them to some immune restoration process. And that could be using ruxolitinib with dexamethasone and followed by either a transplant or by using the CTLs.
And how fast does one initiate the etoposide after starting steroids? I mean, you lose the patient if you don't act fast. But sometimes
Absolutely.
one is reluctant to start the etoposide, or one is confused. So what should
Totally
one
agree.
do?
Totally agree. I mean, it's a war-like situation. You have to gather all your information, and the one thing is look at the patient, look at the lab values, the increase in the ferritin, rapid ferritin. Let's say you give dexamethasone today, and then the next day it's not getting any better. I think I would start thinking of giving etoposide right away within a day or two. I wouldn't wait longer.
And what kind of dose of dexamethasone should be used? Sometimes they have coexisting infections, like say fungal or something, which you come to know in 48 hours maybe. So what kind of dose is safe? when one doesn't know what, one is not sure?
It's a tough situation because will giving dexamethasone, the question I always ask, and the ID folks ask me, giving dexamethasone for a short period of time, let's say it's due to CMV, is it going to change anything? It may not. I mean, as long as you have CMV, that's another classic situation where you can treat the virus. And I think it's okay to give dexamethasone because you need both. You need both antiviral therapy and also you need the dexamethasone. This is the situation Dr. Agarwal mentioned. I think IVIG is a good approach to use because it also helps boost the immune system to some extent, whatever is left to help fight the fungal process. I would not hold back on dexamethasone just because there is a fungal process, unless there is a aspergillus condition in the lung and you have very far advanced clinical situation. That's very different. It's a risk benefit discussion more than a clinical judgment.
Thank you so much.
Thank you, Dr. Pine.
Roshin, Dr. Kunga.
Yes. Excellent lecture, sir.
Thank you, Dr. Kungar.
My question is, out of the 8 criteria, do you give some special weightage to the one of the criteria, whether ferritinemia, HLH, which criteria, or should we wait for all the 5 criteria to appear to start the treatment, or which criteria you will give you the maximum weightage? Hyperferritinemia, HLH, hemophagocytosis.
I think you need 4 at least to have the suspicion while you're waiting for the 5th one, right? So fever, then you have the ferritin, which is high, cytopenias, number 3, and then splenomegaly. So these 4 criteria I think is helpful. If you don't have splenomegaly, sometimes you have low fibrinogen. I think out of those 4 criteria, I think the fever, the ferritin, cytopenias, and also the splenomegaly. What is not included is the AST and ALT, which is available in ETSCORE and also in IECHS. So as I told you, this is designed for primary HLH where you don't always have the liver enzyme elevation, but you have organ dysfunction, whether it's increasing liver enzymes, your alk phos is high, AST, ALT, AST is high, or you have renal dysfunction. I think those are all good reasons. Even though it doesn't fit into this classic 8, you at least have 3 or 4 criteria. I think that's good enough to consider.
Should bone marrow should always be done? Should bone marrow always be done in a suspected case of HLH?
I would always do it, but don't always wait to hear that the pathologist is going to say that there is hemophagocytosis. And you can see hemophagocytosis in even a normal situation. That's the other factor. But if it is filled with hemophagocytosis, then the pathologist is going to say this is HLH. Or if they see hemophagocytosis 1 or 2 here and there, which is not uncommon, they'll say clinically correlate. So I think it's helpful because then it adds and it strengthens your clinical criteria for HLH.
But it's not absolutely required. It's not absolutely required.
Unless otherwise, I think in the setting of malignancy associated HLH, I would do it. In the setting of rheumatoid arthritis, in the setting of maybe a CME infection, in the setting of transplant, there's different conditions, but I would always try to do it. And I know where you're coming from because patients have platelet counts of 3 or 4. The fibrinogen is like 100. Is it safe to do the bone marrow? I think we should do it. There's no other way around it. At least you get an aspirate, you're able to see the hemophagocytosis.
Thank you.
But here, if there are CNS symptoms, you will always do an lumbar puncture?
Yes. So I didn't mention this, at least in the setting of leukemia, we almost always do lumbar puncture and use this triple concoction, hydrocortisone and methotrexate and cytarabine. I think, you can just use methotrexate. It's very helpful to treat because it's the same phenomenology that you see in ICANS, right? So in the setting of CAR-T, patients have ICANS and very severe ICANS. What are we doing these days? We're actually doing lumbar puncture with intrathecal cytarabine. So I think it's all coming around to that same cytokine storm process. If there is clearly evidence of CNS dysfunction, altered mental status, I think I would definitely do a lumbar puncture and consider giving them at least cytarabine.
What is the sensitivity and specificity of soluble CD25? We have in-house, so we get reports by evening.
Oh, that's fantastic. I mean, I wish I wish
For
we could
example,
do that.
our ID guy insisted, so now we are in-house.
Okay, fantastic. That's good. So I think each lab has its calibration. So two things. One is the absolute value. So I think something like 850 to 900 is upper limit of normal. So most lymphoma patients have 1,000, 1,200. So we've looked at all the newly diagnosed patients. But if it crosses 2,400, so that's sort of the threshold, then I think you should start thinking about HLH. If it crosses 10,000, that's invariably HLH. So between the 2,400s and the 10,000 units per ml, I think having serial values, it could be 2,400, it could be 5,000 the next day. And these are situations where you would do it. But I would not take that in isolation. I would combine that with ferritin and other criteria because lymphoma patients do have elevation of IL-2 soluble receptor. So if you look at the publications in Japan and our own series, some of these diagnoses patients can have the IL-2 soluble receptor in the range of 10,000, 20,000, and 30,000. So it's very tricky. I would not use it in isolation, but I would combine with at least ferritin.
What about its sensitivity? Does a normal result rule out HLH?
Yes, it does. It does, but for that moment. Because it's a dynamic process, I think I would at least look at the clinical situation and reorder it within a day or two. It could be a lot of things going on, but if the inflammation still persists and C-reactive protein is high, ferritin is high, sometimes the labs cannot read the IL-2 soluble receptor. So that's a problem. So they come up with this what's called as undetectable or unreadable values, because it could be the assay problem, interference in the assay. When that happens, I would just repeat it.
Dr. Divya, your question.
That was a fantastic update, sir. I wanted to know about leukemia, sir, per se. How common is it, and whether is it in myeloid that is common, or in B or T leukemia per se? Is it common, and what is the timing? When do we usually see? And most of the symptoms are overlapping, like that of cytopenia, fever, which is common in leukemia, like due to sepsis or something, and splenomegaly. So 3 points are already overlapping. So what else do we see usually to judge that it could be an HLH?
Great question. I think we are sorting that out in our own case series for about 100 patients with HLH and AML. So the myeloids are more common than lymphoids. The ALLs can also present with this, particularly T-ALLs in the relapsed refractory setting. With the myeloids, because of the very nature of the AML and they can also, especially the M4s and M5s with the nature of their cells, they can cause this phenomenology. The timing it can be at diagnosis. We've found at least 30 to 50% of the patients at diagnosis, but many times it happens later on. And the later on could be 14 days into treatment when as you mentioned, cytopenia. So what distinguishes them? You're right. So there's fever already because they're neutropenic, they're cytopenic, there's splenomegaly. And that's where we think the ferritin velocity makes a huge difference. And ferritin can be high in leukemia too, right? So it can be 10,000, it can be 15,000. But what we have found is that, and in our series, the baseline ferritin was like 25,000. So it's already high to begin with, but it's the velocity. But if you see a slope, it goes from 25,000 to 30,000 to 40,000. I think that alone is a good enough reason to suspect that there's more than just the leukemia-related events that's happening. And if you do a bone marrow and you do see hemophagocytosis a little bit more commonly, I think that, and then you do the soluble IL-2 receptor. So combination of soluble IL-2 receptor plus this, I think gives you the idea of, thinking about this as an HLH, and then you treat the HLH with the protocol. The problem with treatment at leukemia, and it's Dr. Naval Davar and Amit and Abi Maiti's question. I think we struggle with this. I think what they have done is use tocilizumab. We had a protocol with emapalumab, which were not written up. We had 7 patients with emapalumab. It works very well in combination, and we have found that this ELA26 to be probably the best therapies among the lot for treating the underlying condition. But in lieu of this, I think using ruxolitinib, anakinra very early on, especially when you see this increase in ferritin, because that's the cheapest and the easiest thing to do, I think that's what I would use as a gauge.
Okay. So in lymphoid, a lymphoid malignancy, not in lymphoid malignancy, that is a T or B cell leukemia or mixed phenotype leukemia. When do we start ruxolitinib if we see something like that, along with the steroid, like in induction?
So the Chinese data is starting this with the steroids. So you use dexamethasone and Rux, but then Rux can be also second line because you have a lot of other things to offer. If you're not given etoposide, etoposide still is helpful in the situation. You can use Dex and etoposide and start with anakinra because anakinra we think is going to be very helpful even in this situation. These three drugs are going to be very important. We need to update the guidelines at some point. And the ruxolitinib could be a second line because you can give ruxolitinib for a long period of time. Even the patients can take this when they get discharged from the hospital. The problem with ruxolitinib is the dosing, right? So you can't give the same dosing that you use for other myeloid processes. So I would at least start with 5 milligram BID. So if you do 5 milligram per BID and you're able to control the cytopenias, especially the thrombocytopenia, we've seen pulmonary hypertension as a problem in the situations. We've seen GI bleed as a problem. So sometimes you have to stop and restart. And the other problem with ruxolitinib is that if you stop, and if you stop it for too long, there is a rebound phenomenon. HLH comes back. So that's why it may not be a first line. You need to have some control on your HLH process, and you want to move the ruxolitinib to the second process. If we have not done the Chinese criteria, they've used the Rux with DEP, and I've seen the data, but I don't know that I would use it as a frontline therapy in the situations.
Thank you, sir. Thank you. That was very insightful.
Thank you, Dr. Divya.
Pulmonary hypertension is due to ruxolitinib.
Well, we think it could be due to ruxolitinib because of the indirect effects on the fluid management and the heart, and so why it happens, it's not very clear. I think it's a similar. It's very rare. Of course, we have treated only a few patients, like 10 patients or so. No, you've seen this in dasatinib, right? In dasatinib, you do get pulmonary hypertension rarely, so it's sort of like that.
Right. A related question is put up. Dr. Sham wants to know whether ruxolitinib is a better option than etoposide.
Perhaps. I think we don't know. I think when you have a war going on and you can't say one is better than the other, at least I would use a couple of doses of etoposide because it's easily available. Ruxolitinib might not be easily available. You can't say that one is better than the other. I would try and use etoposide early on and then use ruxolitinib for a longer haul.
Again, our Myanmar colleague wants to know that based on HLH, can you favor ALCL versus Hodgkin as the diagnosis if the histology was very clear?
Okay, so that's a very, I'm sure this must be an experience from Dr. Mint. So many times when Hodgkin's presents in the bone marrow and not in the lymph nodes, it's a rare situation, and that can sometimes be confused for ALCL. And you can also have Hodgkin's-like cells in the setting of ALCL because you have horseshoe-shaped cells that look in the bone marrow. It's very hard to distinguish Reed-Sternberg from the horseshoe-shaped cells. But in that situation, the good thing is that you're using brentuximab, using a variation of either CHP or some kind of AVD type therapy. I think it's very hard to distinguish one from the other. What helps distinguish this is, I think, a good pathology and it's a good morphology in the situation. The expression of CD30, the lack of CD15. I think it's a clinical pathological diagnosis. Sometimes it's very hard to make. We've had exactly those situations that you're talking about, Dr. Mint. I don't think the HLH itself makes a difference. What we have noticed in both the situations, again, it can be confusing, is that the amount of disease can be small, but the HLH can be completely disproportionate. In the setting of ALCL, in the relapsed refractory setting, you maybe see 3 or 4 ALCL cells in the bone marrow, but the HLH is reproring because it's a Th17 driven disease. And you already have high levels of cytokines, high level of IL-2 soluble receptors. So when that is a situation, I would lean more towards ALCL.
Thank you. Dr. Hita wants to know hepatosplenic T-cell lymphoma with HLH and patient not responding to ICE chemo. What will be the next treatment?
So that's a tough situation. So the hepatosplenic gamma delta T-cell lymphoma is the HLH incidence is much more common, and because the spleen is very much involved. If ICE doesn't work, I would use hyper-CVAD without the methotrexate cytarabine portion. But the alternative is to use Campath and ruxolitinib. It all depends on how much of hepatosplenomegaly is involved and the bone marrow involvement. So if invariably, PET scan is not a useful test because you only see hepatomegaly and splenomegaly. Sometimes you see lymphadenopathy, and the bone marrow sometimes is very helpful. You can't use pregasparaginase because when they have HLH, they have very high levels of the transaminases. So in that setting, your next choice is to use hyper-CVAD without the use of methotrexate. If the liver enzymes are elevated, just use hypercytoxin without the adriamycin and vincristine, and then eventually move them to hyper-CVAD. The other option is to use ruxolitinib and combination Rux and Campath because Campath depletes. The problem with Campath is that it can cause a lot of problems. It does get the disease under control, but it also becomes a problem because when you do take them to transplant, you have post-transplant related chimerism issues because of depletion of T cells. But here it's a warlike situation, but these are some of the choices that you have for hepatosplenic T cell lymphoma. If they fail 2 or 3 therapies, I don't think you have anything else other than a clinical study. So I just want to mention in that context, I didn't talk about it, especially in the cytotoxic subtypes. We have an antibody called CD94, and we had an oral presentation at Lugano. CD94 is invariably present in all these cytotoxic T cells, NK cells, and we've seen very good responses in most of the cytotoxic T cell lymphomas, including one patient with hepatosplenic gamma delta T cell lymphoma. So the options are few and far in between, but I would at least use some of the chemotherapies I discussed.
Question different from today's discussion. What are your indications of allo transplant upfront in a case of TNHL?
Oh, so if they don't have HLH, right? So if they don't have HLH and there's a reason to do an allo transplant, I think a few conditions. For sure, you want to do an allo transplant if you have transformed MF, mycosis fungoides. You have ATLL, and ATLL is, I don't know if there's anybody from Kerala here. There's a very high level of ATLL that I've discovered because HTLV is endemic in this population. We have 5 patients in Houston who are from Kerala with ATLL. So don't always forget, and I think we've also had reports from Bombay as well. Right, Dr. Agarwal. So as for ATLL upfront allo transplant, hepatosplenic gamma delta T cell lymphoma upfront transplant, extranodal NK T cell lymphomas, particularly advanced stage, you do allo transplant. For the nodal T cell lymphomas, I don't know that you need to do an allo transplant even if it's a young patient. You can consider an auto, particularly for PTCL-NOS and for AITL. Not for ALCL if they are ALK positive. ALK negative, you may consider. There is still a controversy if they express DISP22. You don't have to do a transplant because they are as good as ALK positive patients. But if there's a disease, it's advanced disease, stage 3, stage 4, I think you need to consider an auto transplant, not an allo transplant. The only exception I should mention is ALCL could be bimodal. You have the pediatric variety and then you have the adult variety. Sometimes pediatric variety, when they're present with extranodal and leukemic manifestation, that might be an exception where you would do an allo transplant.
PTCL gamma delta NOS. You'll do an upfront allo?
I don't think so, Dr. Agarwal. I think that's a good question. It's a heterogeneous cohort of cytotoxic T cell lymphomas. They invariably have methylation parameters. If they don't respond to the frontline therapy, I think it's helpful to consider a transplant. If they fail one therapy, I think that's when I think we'll do an allo, but at least consider an auto at this point in time. I might change your opinion, but we're still collecting a series between us and Memorial because it's hard to identify. Many of them are CD8 positive, some of them are CD4 positive, some of them are double negative, and very rarely they have gamma delta processes. So I think it's a very heterogeneous group, but the ones that have the methylation profile are CD8 positive. I don't think there's a reason to consider an allo transplant for these patients.
Thank you. Dr. Saswat Saha, refractory ALCL, previously received CHOEP, now presenting with HLH treatment.
Yeah, so since the CD30 positive, I think you have a consideration to use brentuximab This is a situation I would, if depending on the clinical situation, if the patient is very cytopenic, febrile in the hospital, we've used hypercytoxin dex with brentuximab. And that could be a situation that can help this patient with ALCL. So at least the brentuximab can salvage both underlying ALCL and also the HLH.
Dr. Hitha, which chemotherapeutic drugs trigger HLH?
It's a long list. I think anything can do that. We've seen the chemotherapy from even leukemias can do that in the right setting. I don't think there's one drug more than the other causing this. It's the context coming to many things coming together. We've also seen checkpoint inhibitors causing HLH. Very rarely, they get treated for some lung cancer or urothelial carcinoma, and then they present with HLH. You do have some immunosuppressives that can cause HLH. So it's a combination of the medication and the change in the immune status that happens. So unlike a lot of things that you see with drug-related effects, right? So I don't think it's a large list of medications.
This reminds me, we have a relapsed refractory Hodgkin lymphoma. He's undergone almost everything, and then he was on nivolumab. And then he came for very high-grade fever. And finally, it was HLH. Florid HLH could be salvaged. Can he ever be given nivolumab again? He has exhausted all
because we don't have too many options. If the patient relapses or is not responding, I would consider, but I would use a lot of steroid cover if I were to use nivolumab, so that I think you don't have this activation of macrophages in that setting, or try to combine with brentuximab.
He's now developed neuropathy. He's received so much of brentuximab.
So that's a challenging situation. Yeah.
Are there any more questions? I'll just say.
I think I see one hand up, Dr. Kirtana.
Oh, yeah. Dr. Kirtana, please go ahead. Dr. Geeta? Okay. Dr. Shilpi wants to know, in adults, are you using H score for the diagnosis of HLH? And what is the cutoff of H score that you're using?
Not really, because you can use any system that you want. The H score is a probability. It's not prognostic. It's a probability, a measure. You still need to look at the clinical parameters. I mean, you can use H score, but I think what you would follow are these things like ferritin and improvement in cytokines in the counts.
Dr. Archana wants to know, is there a role of plasma exchange in CRS?
Good question. I don't think we've really done that. The idea is that you're eliminating all the factors and potentially the cytokines in the blood. It's theoretically possible. I don't think we've done that, particularly in the situation.
Right. I think we have covered most of the questions in the chat box. Dr. Geeta, you have a question?
She said she's not able to unmute.
Okay. She's put up something here. Not able to unmute. Okay.
Please feel free to email me.
Please email to him.
Yeah.
Okay, Doctor. Yeah, thank you so much. Wonderful. Lecture was great, and then this QA session was great. Absolutely. So many things got sorted out. Very, very
Thank you very much. I know there are a lot of good questions, and we have very few answers. We're still trying our best to improve this.
Difficult disease. You still sorted out many of the problems that we face in day to day. If the INTAS team is there for giving the vote of thanks, Somnath.
Hello, sir.
Who is that? Geeta?
Yes.
Yes, sir. Yes, sir. I was not able to unmute before.
Yeah, go ahead now.
Yeah. Thank you so much, sir. It was quite informative. I am a hemopathologist. So I had typed it in the chat box also. I recently had 3 cases of HLH, and 2 of them showing a florid B immunoblastic reaction, which almost looked like a high-grade B-cell lymphoma. However, there were no nodes, no petavid nodes. So just wanted to know your experience, Dr. Iyer.
Yeah, so we've seen this. I mean, florid B-cell hyperplasia, immunoblastic reactions, they can present with fever, B symptoms, sometimes cytopenias, and it's very unclear what's going on there. And okay, yeah, you're right. Sometimes you see EBV markers. But these could be heralding symptoms of a subsequent leukemia. And what's that progressive regression of the germinal center? They all have, the symptomatology, and some of them can become a Hodgkin's lymphoma, some of them can become a T cell follicular lymphoma. We've seen some of these florid immunoblastic reaction that becomes TFH. So I think the only thing I would say is clinically some resolution with the use of steroids, if possible, if there's no active disease, and keep a close watch for the transformation to a lymphoproliferative process.
So this was in the bone marrow.
This is in the bone marrow. Okay. This is not in the lymph node. So this is slightly different. Yeah.
So probably when I read, it said that EBV could cause such reactions. I could not do a PCR, though serology was negative. And another case where there was cells which were looking so bizarre, I could not morphologically classify them itself. So the second patient actually expired, so I could not do further workups. I just want to, because people tend to ask us that if you're finding immunoblasts, can it be a lymphoma now?
I don't think so. I mean, morphologically, you have to make that call, right? It's sometimes very, very difficult. If you do CD30, many times these immunoblasts actually express CD30. Even if you do that, I think it's a clinical pathology.
Okay. So, Somnath?
Yes, sir. Thank you very much, sir. I would like to thank for the most elaborate session that Dr. Swaminathan Iyer sir has given up. Thank you, Dr. M.B. Agarwal sir, for bringing up the most eminent speaker. I would also like to thank Dr. Amit Khurana sir. Yeah, we do have our Vice President sir, Mr. Arun Hegde sir as well. So it was so good. I mean, the session was so liberative, whether for CAR T cell therapy or for the different kind of molecules that we have discussed that were so much insightful. I would like to thank once again. With that, I would like to in order to keep the ball rolling, we are still eager to wait for the next session. So those sessions are so much interesting that in the period of silence, I really enjoyed it. It's totally a mesmerizing thing for me. Thank you very much, sir, for allowing us.
Thank you.
Thank you very much, Dr. Agarwal. I think, as always, you've been very kind and teacher of teachers. So thank you very much, Dr. Agarwal.
Have a wonderful day ahead, Dr. Iyer, and wonderful. Good night to everybody from India. Bye-bye.
Thank you. Good night. Good night, everybody. Okay. Bye.